PM. And if you, the roll call.
I'll do it. Director Goodsell? Here. Director Burker? Here. Director Garcia?
Here.
All members are present.
If you stand for the pledge of allegiance.
I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Item number 4, approval of request for remote appearance by board members. We don't have anybody assigned to that.
Correct.
Number 5, consider approval of agenda. In the case of an emergency, items may be added to the agenda by a majority vote of the board of directors. And emergency is defined as a work stoppage, a crippling desire, or other activities that severely imperils public health, safety, or growth. Items on the agenda may be taken out of sequential order as their priority is determined by the board of directors. The board may take action on any items appearing on the agenda. Do I have to motion on it?
So I saw one. I was listening to the phone.
Yeah, it's my favorite word.
Any discussion?
That's what-
Right now, you're right.
So, all in favor? Any opposed? Item 6, public comments. At this time, the board will hear comments on any agenda item. If any person wishes to be heard, they shall stand, address the president, identify themselves, and state the subject for comment. Time limit for each speaker is 3 minutes individually per item to address the board. Individuals who wish to speak on multiple items will be allowed 4 minutes in total. A total of 15 minutes shall be allocated for each item for all members of the public. The board may find it necessary to limit the time allowed for all public comments on items not appearing on the agenda or any one meeting to 1 hour. Any public comment? Any public comment? Moving on to consent. Any members of the board may request that items of the consent calendars may be removed for discussion. Items so removed shall be acted upon separately immediately following approval of items remaining on consent. Approved minutes for meeting of October 16, 2025. Any discussion? All in favor? Opposed? Item 8 for discussion and for board action. A discussion and a possible approval of bylaws of the Imperial Valley Healthcare District Finance and Budget Committee. Yeah, Mrs. Ochoa.
Yes, thank you. So the draft bylaws are attached to the agenda packet. Hopefully you've had time to look them over. They follow closely the conversation the committee had at our first committee meeting. There's preamble, membership term, meetings, public meetings, quorum and action, and the duties and responsibilities that align with the IVHD bylaws, compensation provision and amendment. There's another, so if you're inclined to accept these bylaws, which I do recommend, these will govern the committee, how the committee runs its meeting. I do also want to ask whether this committee wants to bring a recommendation to the board regarding SB 707. So I'm going to give a thorough update in my GC update at the December meeting on SB 707. But SB 707 is a law that passed in October. The governor signed it. It's effective January 1. And it's got a lot of very sort of burdensome requirements that we're going to have to incorporate into our public meetings, including, for example, Spanish translation of agendas. There's a bunch of stuff we're going to have to do on the staff side. But one of the upsides to the bill is this bill authorizes what they call subsidiary bodies of local agencies to conduct teleconference meetings. So board meetings, full boards still have to be in person. And it extends the sunset provision of AB 2449 out to 2030, which previously was gonna sunset 2026. For board members to attend virtually in certain circumstances. But subsidiary bodies, which they define as basically committees, it's gotta be a body of the board that is, does not have decision-making ability, it's recommendation and advisory only. It basically knocks off everything that this committee and all of the other committees are, and it says the committee meetings can be entirely virtual if you want. So that is a huge convenience, especially for staff, board members, if you're remote. You don't have to make the same findings that you do at AB 2449, like you don't have to like be sick or caring for someone. You could just choose to take the meeting from home. There's some requirements for staff. Basically, you have to have a place for the public meeting for the members of the public to show up. So we would still have to have the auditorium available or a place available that's publicly accessible where they could listen in to the meeting if it was going to be over Zoom. And you have to have at least one staff member here to host and say, if there's a virtual issue where a member of the public can't see the Zoom or can't hear correctly or whatever, someone has to be here, but it could be a staff member. It doesn't have to be a board member. It could be the board secretary. It could be anyone that we designate. But if this committee, you're the first committee that's up and running. If this committee and other committees want to implement this or have this allowability, flexibility, the full board needs to make findings, which is super simple. We could write it up into a resolution and just say, yeah, and you have to reaffirm the findings every 6 months and say, there's a good reason for this, makes the meetings more publicly accessible, it's more convenient for folks to be able to attend. There's a couple findings you would have to make. But I can write that up for you. So my question is this something that this committee wants to recommend to the full board so that you can have virtual meetings if you want? You can still come in person. Nothing prohibits you from coming in person and attending the meeting in this location. It's really just like, do you want to? Do you want to have that flexibility or not? With the understanding that, without these findings made by the board, you wouldn't be able to attend virtually unless you had an AB 2449 excuse. And a limit. AB 2449, if you meet once a month, it's only 2 meetings a year. We meet twice a month, so you get 5 meetings per year. But with this, every single meeting could be virtual for a committee. So it's just something to bring to your attention, so that, we can, it's something that would be probably incorporated into the bylaws if we wanted to do it that way. So that's sort of my question is, do you want to bring that recommendation forward to the board or that request?
Flexibility. I still see myself coming to you in person. I like that. The flexibility.
Good news.
Back where that was that was the doctor's lounge.
Oh.
Yeah. So we need to move.
Yeah, so I recommend you approve, just so you have bylaws in place. And I'm happy to answer questions if you have questions about the bylaws. They're super straightforward. It's just 2 pages on purpose so that they're really short and sweet.
I really like them.
Oh, good.
They're just so fair and concise, and there's no room for assumption.
Yeah.
So that's, I always tell my docs when document, don't put all these colors, what machine you use and stuff. Put what you did, because someone could assume something.
Right.
So yeah, I like it, short and sweet.
Yeah, good. Good. Okay, so my recommendation would be, to approve the bylaws, so you have approved bylaws in place. And then what we'll do is we'll bring the recommendation forward to the full board to have that discussion. You guys want to make the findings for SB 707. If the board says yes, I'll bring back revised bylaws to the next committee meeting that just say the stuff about virtual meetings. It'll really just add one paragraph. It won't be much.
Second. Any further discussion? All right, all in favor? Aye. Any opposed? Motion carried. Item D, review. of-
Can I request that we do the other, let's see. D, E, F, and G while we have Carrie here, so she doesn't have to stay for the whole thing.
Okay. So we'll move on to item B at this time. Discussion and or possible action to recommend to the board of directors approval of authorization to approve the Oracle Health PHR nursing mobility staff reference.
So I'm trying to find it here real quick, so I have it. Go ahead and ask a question.
Health, right?
Yeah. Yep. Uh-huh. Yep. There's geofencing. So you want to explain how that piece works?
But we'll probably mount it just similar to how they mount it to Ascom devices currently. So they'll be checked in and out, on choices.
That was my introduction. Cause I could stick it in my pocket.
Yeah, and they all have to be recharged. Like at the end there too, so they're supposed to go in and put it in. Yeah, initially it will be a bit of a learning curve for some people because yeah, they will stick it in their pocket. The other thing that this does is we're looking at moving everything to Teams and moving away from the Tiger Connect and saving money from that perspective. We've worked out a way to be able to put the Teams on that device. And so when they can use it and get a hold of a provider and stuff that way on that specific device as well. It will also, it gets rid of the need for the WOWs that we currently have, which is workstation on wheels. That's what that means. And if you go upstairs, they're either cluttered in the hallway in some places, or there's a room that they're all sitting in right now because they're charging or whatever the case might be as well. And so it will help us with some of the room space that we need as well. And the idea is also that when they're utilizing that piece of it, they'll be able to hopefully ideally capture more of what they're actually doing with the patient at that time and not miss it going back to try to chart on it later or what have you, so that there's more pertinent available information available to the provider, the hospitalist, and so forth. And it's a big one. So the idea on this one too is it's going to go to right now we are going to essentially be the pilot group, or we'll do it here, and then the idea is that this expands out to El Centro as well as we get to that point. Yep. Yes, because it's a Sterner product. Yeah. But it is expensive, but it is something that we have budgeted for. Because obviously buying the handhelds and then all the other components with the training and implementation and so forth. And how long did we anticipate implementation? 8? Okay, 4 months, yeah.
We need to have it reviewed by the tool.
Yeah, so I will have it
Yeah,
reviewed
so-
before the board,
Okay.
Yeah.
before it goes,
Yeah.
for
Yeah,
sure.
we just got it to her just barely a little while ago, so like she hasn't had time, but we wanted to make sure it came here so you guys could see it.
Yeah, it'll be reviewed before it goes to the full board, for sure. Yeah, and I will try to have stuff reviewed before this committee meeting, but sometimes it's also.
When
okay
she
to
gets
not
it.
have Yeah, and sometimes it's okay to not, because, I mean, for all we know, you guys might change things or not accept it or give us direction back, and so. Yeah, for sure. Yeah, and this is one of those items that would be on consent. Yeah.
This one wouldn't, because it's 304.
Oh, I thought this was the $80,000 one.
There's, no, this one's a big one. Yeah, the 60 handheld devices are 120,000 themselves, and then the. Oh, yeah, no, not a problem.
Everything is here.
So yeah, this is kind of that next step for us to do a little bit more with what we're actually, how we're able to integrate better with Cerner and use it more up to its abilities than what we are right now. And ideally, the other idea behind this is that it allows the staff to be able to focus more on patient care than, worrying about remembering stuff for their charting. And so we can get better results from their charting because they can do it on the spot. They'll have it with them. They can do it right there. It's not that's part of the issue, is like wheeling a big old wow into a room is obviously can be very cumbersome. And it also makes it so that they can be more person to person as they're having conversations instead of like on a computer. Yeah, we're not the first people doing it. We're just finally getting it here. Yeah, the one thing that we have to worry about, and that's why we do have things in place as far as our protocol for when the power goes out or something like this happens and they go to paper charting and then get that information into the system after we get power back up or we get the system back up, whatever the case might be. Because we did have, I don't know, you guys probably don't remember this because when it happened, we had an instance. I'm trying to remember when that was, but when what was that group where it all went down, and so like everyone, flights were delayed, EMRs were down for a while, huh?
Amazon.
Yeah, the Amazon Web Service, like all that stuff went down for, in some cases, it was, some hospitals were down for days. We had about 2-3 hours that it really hit us, but then we had to do other stuff on the back end. Oh, yeah, that one too. Yeah, so there's stuff like that happens that we have protocols in place for when those things kind of play out.
Make one list of it,
Yeah.
right?
Yep.
I think that's how you use it.
Yep.
Okay. Yeah, okay. Do I have a second? Okay. Any further discussion? All in favor? Aye. Any opposed? Item E, discussion and or possible action to recommend to the board of directors approval of authorization to approve the renew Sparkita email system, email system.
All right, I'll actually turn that over for,
It's a spam filter, so it's just another year renewal.
I'm surprised to see how many things were actually blocked from time to time.
Oh, it's unblocked.
Yeah.
It's still not blocked, but
and then if you wanted to maybe just give them a little bit of the rundown on what the idea is, like, this is just for a year. What's our plan afterwards if we come together?
Obviously, we can't put them.
so it's just a year renewal, probably I don't know, Q2 2026, we'll make a decision on, what vendor we'll go with, but for now, we need to maintain what we have. You know, we have the services.
'Cause normally we would do it for a longer than a year.
But what-
So those,
Something you guys.
yeah,
And it may not even be either of those two. It could be something completely
Right.
different. So.
That would have.
Because well, there's the contracts that are in place, like, so if we try to, with the timing on everything, if we try to do that now, it would, I don't know that it would work very well for an implementation, only to do, if we decide like, if they're on that now, and then in 8 months, we're going with somebody else, then we made a change and it's more work on our end to make that change right now than it is to maintain what we currently have while they maintain what they currently have, and then make the choice on what we're going to do together. The other side of it is, the other piece of it is for some of those as well. Once we are together, it will make it much easier for us to negotiate better rate and some of those type of things that would work better at that time. Yeah, and there's a couple of those that are like that because our contracts don't quite line up in a number of these different areas. And so, like, for example, as we're trying to move everybody onto the same email server right now, or to just have the same emails, part of that is the issue that we have with the Microsoft licensing that we have versus the here at Pioneers versus the licensing that we have at El Centro. And so we're actually, hopefully, we'll get out of that one with that El Centro's currently under, but then El Centro will be on it for a month, a new one for a month before we get it on the same one that Pioneer's on at that better rate there. So we're doing a lot of funky stuff to try and make it work so that things hit at the right time. But still move things forward as quickly as we can.
But this is a
GPO, yeah.
And GPOs by policy are not reviewed by legal, the group purchasing order, they have their templates and, okay, even if I reviewed it and recommended changes, they wouldn't be implemented, so it's not. And it's presumed that you're getting the best price anyway, and you get the best sort of deal and it's protected because of the GPO.
Question for you, is this for a year or for a month?
A year.
Because here, does it say here, there's one item,
it's the quantity of months worth, a year's worth of, so it's purchased by month, and
Yeah.
then it's times by the amount of users per month.
Okay.
So it's a year's worth of licenses.
Yeah, 16,152 for that. It's just for the entire year. Yep.
And this is one of those contracts that would be on consent. And so what we imagine the staff reports would look like when it gets to the full board is like this, but hopefully we can add well, and it would be on consent, but probably right above reviewed by legal, there would be ones like reviewed by finance committee, yes,
Yeah, that
no.
would work.
And then they just check the yes, and so that way the board can say, oh, finance committee reviewed, feel a little bit better about it. And if it didn't make it to finance committee, but it's time sensitive and it needs to go to the board anyway, they could just check the no box and then the board would know, okay, so maybe this is something that we have to ask questions about or review in a little bit more depth because it was not reviewed by the finance.
that's a good idea.
There will be a couple of those that will come this next time.
Yeah.
Just so you know.
To it, so there probably will be contracts that come to the board that haven't made it here yet. But the idea is once things get a little bit more structured, to have all contracts run through this committee first, and then to give that board the peace of mind that this committee has reviewed the contract before bringing them to the full board. Because if there's an issue with the contract, this committee would say, hold on, this or that, or I don't want it. And then it wouldn't be recommended to the board. Or if it would, because there's some reason that it's pressing, then you could say, it was a 2-1 vote or whatever, if there was an issue with finance. But that way, at least if you have the yes, no box checked, the full board can say, okay, this is recommended by finance. And that's why this is one of those, and given the amount is $67,000, it would just be on consent.
I'll have them added.
Any further discussion? All in favor? Any opposed? Motion carried. Item F, discussion and or possible action to recommend to the Board of Directors approval of authorization to approve the Oracle Clinical AI Agent, CAA.
So currently we're utilizing this in the clinic, and how it works is you purchase so many of them, and we purchased so many of them for the this contract period for that, and we've surpassed that amount, which is also very positive because it means it's being utilized more than we thought it would be. And so this is we're asking for another 50,000 notes on this contract, and so that we can be up to date. And then that's something we're working with the El Centro side on as well to integrate it across there as well. Because currently they're not using an AI scribe in El Centro at all. This one, the other piece of it too, also to go back is that we've expanded the use of it. So initially the use was just in the clinic, but now we're expanding the use of that into the ER and other areas. And so we need some more to be able to facilitate that as well. Anything else to add to that?
And I will have reviewed that by the time of the board meeting also. Hasn't been reviewed yet, and I'm talking to our data privacy folks just about the terms of this one because it's a new area, generative AI, and making sure that there's protections in place under the agreement to not allow the AI to, I mean, it's in a contained universe from what I understand, but making sure that we're not breaching like HIPAA, data privacy, patient health, privacy, and other stuff that's out there in the AI new law area, so that the district remains protected while being able to use this very cool tool.
Yeah, and that was one of my questions, so 160 per note, but because it's so new, you know, is there any better rate out there? Or?
Well, there probably is. But I would also add that this is the Cerner product. This is the Oracle product. Anything else that we would do, there would also be an implementation cost and some other things associated with it. Like one of them that we looked at before had an implementation cost, and it was per user per month that you paid. Much different setup than this is by the note. I'm hoping as they go along that it turns into something that just comes as part of that, and we stop paying by the note. But it is well, we technically already have it on there. Yeah, the difference is this one just was April or March that we started.
It was
February.
The more notes you buy, the cheaper the note.
Yeah.
But if you don't,
that.
yeah, but if you don't use the notes, you lose them, so
Yeah.
you kind of run that risk. But the other item that's coming to in December is going to be the clinical AI orders agent. So not only will it draft the note for you if you talk to the patient about the orders, stuff like that, it'll actually put the orders in a basket for you, and that will come at an additional cost.
That's cool.
Yeah,
So
so
it's so efficient. I mean, this is $6 this one here, because they get to finish their notes and it goes, drops down and then you fulfill it
Mhm.
very quickly, whereas before, when the doctors are sitting there 5 weeks out and then transcription.
And that's the next part of it. It will actually code it based off of what's in there. So it'll take it and show what you should code, and then it'll ask the providers at that point in time, just like it does with the like the order for, like, if they're talking and saying, okay, Anola, let's order you an MRI of your brain or whatever. Then it puts that in there, it drops it, and they still have to go in and hit it to approve it to send it through. And same thing if it's like something for a prescription that needs to go to the pharmacy, same kind of thing. They still have to hit it to go through. And it's the same thing they do on their notes right now. It goes and sits in a spot, but they go and review it to make sure it captured everything appropriately. And then they hit approve it to sign it. Same thing will happen eventually. The next step is with the coding. And so it will code what they're doing, and and that's how coding is supposed to work. It's based off of the note that you provide so that you can have the backup for that. And then it will start to show the provider, yep, this is what you should do. And they still have to go in and approve that for the coding. And then it will go to billing from there to, again, do the secondary review. But some of the other pieces of it that it does too is as the conversation happens. So it's easy to say, for example, and I'm kind of getting into the weeds here, but just so you guys have full understanding of like where this ends up going. Like if you're in there and you're having a conversation with your provider and you came in for, you know, a stomach ache or something like that, but then you start talking about other things like having a hard time sleeping and, you know, that kind of stuff. The AI picks that up and then it'll make recommendations to the provider to have a conversation about, you know, possible sleep apnea, other things, and have other questions that they can do so that they can, you know, we can make sure that we're catching those things when it's happening instead of later when it becomes more of an issue. It's picking up those little nuances and flagging it so that they can have that to, oh, I missed that part. It didn't. Let me double check.
Is it more bilingual or
Oh, yeah, yeah.
can it translate also? So if the patient's speaking Spanish?
Well, the one that we have right now does.
So the notes are even.
And what's the accuracy? Do we know the accuracy rate of the translations and all of the?
We've had, because we're using it, I mean, so we know the Spanish is pretty accurate based on what the NPs are using it.
Yeah, the most of them that I've seen that have come through have like a 98+% accuracy percentage.
Does anybody read them afterwards to make sure that it's correct?
The provider, yeah, the provider has to go through it, make sure, yeah, and then they, yeah. Because it's the same thing. So if you have a scribe who's doing that for you, it's the same kind of idea, right? Like you, as a provider, you still have to go through and review it and say, yeah, they caught everything, or no, they didn't. I want to make sure this gets added onto it. And then that's part of the idea that's supposed to work with that makes it the AI part of it is when they go in and do that, AI learns from that and understands, okay, next time I need to catch that, or next time I need to change that. If it doesn't do that, if it doesn't learn, then it's not really an AI product. It's just a software product. So, yeah,
No, I know it's closed loop, right? But is it able to learn from other providers? Is this information that knowledge kind of being built somewhere and spread to the other units in essence?
I'm sure Cerner's using it.
Like use group among people who are using it, you know, and they have different tiers of like acceptance levels for different like family practice versus cardiovascular. So it learns from everyone and it goes through like a validation of tiers of where it's at in like the general use, or is it still kind of in validation? So it's rolled out to everybody, but they give us like every month what level it's rolled out in terms of acceptability and learning.
Is it also provided the latest knowledge? Like, so like, let's say latest research is coming about and maybe the provider is not aware of this new research. Would it still, if it's been just new, would it be maybe flag something that the provider may not have seen, but? because of
Not
this
yet, like
research?
right now it's mainly, you know, just listening and drafting the note. It's not doing. any
It's,
sort of
yeah, it's
sophisticated,
called
like-
ambient AI. So it's, yeah, it's more,
Yeah,
Yeah, and I think that would be something like about halal laws and AI. It can't really, you know, the diagnosis and treatment.
or, yeah.
but some of it is actually starting to go that direction though, because there are things, so, you know, if I was, you know, like my grandkids, I'm telling them, don't go into radiology and don't go into dermatology. Because most of that will actually be taken over by AI. Because essentially what they're doing is the same thing, but they can do it faster and they can process it differently as they're looking at images to find, you know, hairline fractures to minimal growths. And then same kind of thing, like you can have there's that one too. There's one where they can look at the piece on the skin and be like, you know, and that's the different piece. So if you look at it from the standpoint, when you have like a dermatologist, for example, or even a radiologist, and it takes them, once they get into it, it takes them a good 15 to 20 years before they're considered an expert in the field because of all the learning that they do and what they have to figure out and how they like, okay, this makes sense and so forth. And then after they hit that point, and it obviously this depends on each of the provider because everybody's different. Some of them will go longer than others, but usually there's another 10 to 15 years after that that they work as an expert. And obviously they're still continuing their craft, right? But then they retire and it all goes away with them. Like it's not retained by anyone or anything or anybody. And so it's the same information that you keep going through that like you teach and you get to a certain point and it kind of stops and then you're waiting for the next group and so on and so forth. AI doesn't have that. It doesn't stop. It doesn't retire. And so it gets, as it keeps going, it gets better. There's not a point where it stops. It just, keeps going. And so as it learns and as it keeps doing it, and then also that's the other piece, like some doctors are pretty crazy and will work, 16 hours out of the day. AI will do it 24 as far as reviewing all the stuff and looking at it and understanding and then learning from how that's working. And so it will get to the point where we can take an image and like in the ER and drop it, and then it will kick over to the emergency room physician right away. This is what the problem is. There's a break. There's no issue. There's whatever. It'll give it to them like that. Like now we wait for it to happen. We wait for those stat reads to come. And especially like it's really difficult at night because our radiologists are here on site. And so we get some fairly quick turnaround from them. But you're talking when we can get a, 40-minute turnaround time on something like that, it'll be 5 minutes tops. And at nighttime, sometimes that goes beyond that, and you're looking like an hour plus to hear back because somebody is from somewhere else is looking at it. And so those things will happen much quicker, which will make it much easier for us to provide timely care for people in those situations, in particular in the ER. And it'd probably even get to the point where, like, as far as like, oh, I don't know about that mole. Let me take a picture of it, and then on your phone, and then comes back and says, yeah, you probably need to get that removed, or no, you're fine. Because it's again using all of that data based off of what something looks like to be able to tell you whether it's cancerous or not, which is years and years and years that it takes for a dermatologist to be able to do that same thing. It will do that and keep learning and just keep going. So there's a lot in that field that will get to that point where it will probably replace some of our doctors from that standpoint, from a diagnosis standpoint, because of what it's capable of doing. But we're not quite there yet, but I would imagine, up to 10 years from now, that'll be the norm for radiology, dermatology, and a few others like that.
Yeah, all that imaging, I think, is gonna, the error factor is gonna go way down.
Mhm.
I saw already on YouTube where they had an X-ray of someone's lungs and they're and highlighted the area, so.
It can catch things much differently. Like even as we do like some of the tele work that we do now, that's the part that's also interesting. So when you use one of the telemachines and depending on how they're set up, some of them will have it set up for them to be able to, listen to the heart. So it's hooked up to the machine. You got a nurse in there and they do the stuff like that. When they hear it on the other end, they're hearing that in high definition. It's picking up some of the things that they may not normally hear with a regular stethoscope. Like it will pick up some of that stuff and the doctor can be like, oh, hold on a second, go back. That sounds a little different, right? So there's like, that was kind of some of the start of what we're able to do with some of the digitizing of things. And this is just going to be more of that continuation where we can catch things quicker and stop people from having to go through costly surgeries and other treatments.
Limbo, trying to figure this out.
Right. Yeah.
Any further discussion? All right, all in favor? Any opposed? Motion carries. Item G, discussion and or possible action to recommend to the board of directors approval of authorization to approve the Affinity Data Archive Phase 3 CAA.
I'm gonna turn that one over. She knows that one right over.
So we've already archived most of our legacy systems after we went live with Cerner, the bigger ones, the only ones, well, I'm sure there's more than, I'm sure there's some lingering around, but one of the bigger ones that's left is Affinity, because we were running down our AR. So that's just the archive of that system, we feel like we're at the point where we can archive that. So yeah, we want to get it archived before the next read-only renewal, which will be November of 2026, so. That was fine here.
Mhm.
It's for 5 years, so we pay 50,000 a year for read-only access to Affinity. This, I think, brings it down to 35,000 a year or something. 36. And then I'm guessing if there's 10-year, I don't know what the retention policy is off the top of my head for rev cycle data, but I'm guessing about 10 years. Get rid of it. Is it 16?
Yeah.
Or something like
10.
It's 10, yeah.
So I so move that we approve the Affinity data archive phase for the
Any further discussion? Okay, all in favor? Any opposed? Okay, motion carries. Thank you so much.
Thanks, Gary.
And go back to item E. Review of October financials, Department of Operating Law Statements. Are you looking?
Okay, so I passed out to you guys a narrative. It's a little bit different than the narrative that you guys have seen previously. I was trying to kind of shorten it and give you the information that I feel like you guys are gonna read, because I don't know if you guys all read the whole narrative, and it's just, so I want your opinion on this. If you guys want me to go back to the more information, this kind of just goes, I feel like a little bit more organized. So I'll kind of go through this since I know you guys didn't see it. I just kind of gave you the financials and threw them at you over the weekend. So we're gonna start out with the financial operation for the month of October was a profit of 547,000. That's against a budget loss of 585 for the year. So obviously we're doing a lot better than we anticipated if you're looking actual versus budget. The graph will show you the ups and downs of our profit and loss over the last 12 months. Your graphs will always be a rolling 12 months on there. The big up in August, as you guys will remember, were some FEMA funds that we received. The next page is just going to be the patient volume. So this is going to be like our key operating volumes. The first one obviously is our patient days. We were under both budget and prior month for October, and but the year to date for patient days exceeded budget and exceeded the prior year. The skilled nursing was under budget, but we exceeded the prior month volumes. So we are at an average daily census of 73. I think last month we were at a 68. Your graph will also show you those two paragraphs information for you. The red will show you the skilled nursing. You'll see that it went up, and the blue will show you the patient days. You'll see that it went down for the month. We were, as I stated in July and August, we did see higher census during the summer. So October is a little bit lower than we're used to, but usually it is kind of up from the summer as well. This next one, so the key operating stats is we're going to look at deliveries, the ER visits, surgeries, the rural clinics. So we have 3 rural clinics that are combined in that one line item, and outpatient non-ER. Those are your lab, radiology, cardiology, any of those items, ancillary that are outpatient, that are not ER or the clinics. So all of those for the month of October were below budget and below fiscal year. The only one that exceeded the budget was the rural clinics. So down below, I'll have to give you the actual budget prior year for just the month, and then the next columns are your year-to-date columns for those as well. And then the next page just gives you that same information, but in a graph format, so you can see your ups and downs easily for those as well. Next is our gross patient revenues. Gross patient revenues. I don't know if I said that correctly. So we did exceed our budget and actually prior month by 4.6 million was the budget, and 3.2 was prior month. We had extremely high gross revenues for October compared to September, which is odd considering most of our census was down. Some of those were obviously charges that didn't get inputted in the previous month that got inputted into this month that were just really late. So our net revenues were kind of still consistent from month over month. We just had a difference of about 0.7%. So that's staying very consistent on the net revenues. The net revenues is going to be your gross patient revenues minus the deductions. The deductions is that estimate of what we believe we're not going to collect based off of the different reimbursement contracts that we have with the payers. The operating expenses were actually under budget, but I did want to put on the daily in here, like I've told you guys before, because I feel like looking at prior month is sometimes difficult when you have 30 and 31 days. But so we did spend a little bit more daily per month in October than we did in September. By about 6%, we exceeded the prior month expenses. Your next graph is going to show you everything I just talked about. So you're going to have your gross revenues, your expenses, and so forth on here. We're staying very consistent. So considering we do have a positive bottom line, that's a good thing as well, that we're staying pretty consistent month over month for that. Thing that is not staying consistent is our days cash on hand, and that is because of all the IGTs that are going in and out. Basically, we got money in October, and we had to send another 3.2 million out in November. So it is a very volatile for the days cash on hand. But you'll see here we did go from 61.8 in September to 78.8 in October. Then it'll go down again in November and go back up in January. Our debt service coverage ratio is at a 2.06. The one paragraph I didn't speak on, we do have to keep a 1.2 for our bond covenant. So far we're still doing well on that as well for that ratio. The last graph that I have here for you guys is just your fiscal year to date, and they have the budget, and then it will have our actual. So far for fiscal year, we have a $3.1 million profit. I did add in that paragraph a sentence that I'll keep there all year, just to remind everyone that we did have FEMA reimbursement of $1.2 million that goes towards that $3 million profit. So that is the total finances for October before we get to the detailed department P&Ls. Do you guys have any questions?
One question I would have that with anyone sort of was, I was looking at the other paper, right? Was the operating indicator.
Mhm.
That was my question is this based on data service or clean data?
So the clinic, well, it will be once the charges are in. So if they don't have they don't have the charges in there, they don't get credit for it. We were able to automate the statistics, and if the charge isn't there, it doesn't populate on the
Right.
statistics.
So that was my question. Because you see the numbers and you're like, whoa, these are low.
Yeah.
And then the next time you'll see it.
They're very high.
Like the wound care.
Yeah.
Oh, there's a lot of charges for the wound care, you know, are we seeing the DR, the charges in full out?
Correct. Yeah. And I do want to note, I don't know if it's on here. Oh, no, it's not on here. So I did need to look at the GI scopes because the documentation I have in there had them on there, but it only had a couple, but I know we have to include the ones that are at the ASC, but so I'll have to get those numbers added. Yeah.
I realized that. But yeah, that was just my question. It's data service or plain thing, so it's probably based on plain. Okay.
The format,
Yeah.
you
I mean,
guys,
you could think about, I'll send this to the board. I feel like it's, okay.
Kind of like both. They're both.
They're both the same, but yeah, yeah. So I'll try this one to the board to see what they say. It does, yeah, it gives you a lot more detail of like this percentage, that percentage is, and this, because we put it in the paragraph, but then we would give this information, and we put it in a paragraph and then give this information. So I just kind of left it in the charts.
this is like the Sports Center edition.
Yeah, that's true. The highlight. Oh, yeah.
Yeah. Oh, why did this speed? And then you go over and look at the detail and go, oh, okay, or ask your question.
Yeah.
So that's how I like it.
One thing I would ask you guys, and I'm only asking full disclosure because it bothers me. So I'm asking you guys your thoughts on it. But like on the KOIs, would you want it to see it split out so that you pull out the deliveries and the surgeries because those numbers are so much smaller? Because
Yeah.
when you look at that, you're seeing thousands versus the hundreds. underneath there. And so I think that like, it makes it harder to be able to see some of those changes in deliveries and surgeries, where it's much easier to see it for the clinic and the ER visits and so forth. So if you pull them out, you could see them differently because the scale would be different.
We brought in the graph, maybe, we stretched it out a little.
But
We'll just pull them out.
yeah, if you pull it
easier.
out and do two separate ones, you'd have a separate one, because the value would be, the value on the deliveries and the surgeries, that value is much smaller than it is for the others.
Yeah.
The volume is higher in see, and you can kind of look at it and say, oh, well, it's school physical, or it's vaccination time, then you can explain that, because to me, RHCs should provide services to our hospital, so therefore, there should be more surgeries, there should be more outpatient services, and there should be more.
And this will look,
We offer.
exactly, and this will look a lot different too, when we add El Centro's numbers into it. So that's probably the other reason to pull some of those out too, just so that you can see how those will be a little bit different, because we'll be adding in all of those components of it, and keeping those separate so you can see that. We do know, like, even right now, there's a lot more outpatient stuff that's done at ECRMC than there is here. And so you'll see some like spikes there, which will be part of that idea too, is saying, okay, how do you guys do that? How do we, and so that we can make that happen over here too. But you'll see that in a different, when those come together, that there'll be some changes that would happen on those that are significant. Yeah, absolutely.
The only comment I would make. Because we can supply all. There's no shortage of, there used to be an outbreak shortage of data. We are able to find much more data. The only reason I caution you is because you're going to see all these things this high level. And then if you want us to, we can drill down into specific details for you. But if I start giving you so much data, it will
You'll get
very
lost.
quickly overwhelm you. Harvey and I and Chris, we look at this stuff every single day. It is completely overwhelming and once or twice a month. Just a good tip.
Yeah, that's why, that's why I like this, and that way I can go and look if I want to or have. And otherwise, I'm just like, they're taking care of it.
We'll absolutely start bringing the two pieces together. You will see them separately, and then you'll see them combined. That way we can say, well, what's happening over here? Why is that not happening over here? Why is probably performing so much better in this department? Why is UCMTM? Second quick question,
Yep.
when looking at the form, the key operating indicators, at the very bottom, is the net income portion, operating margin.
Mhm.
Okay, there it says, so for the actual is actually $401,000, $401,336. And then the budget was negative $879. Is that accurate? I mean,
Yeah.
Isn't the budget, the idea behind the budget is what you anticipate on?
Correct.
Yeah, it is. So there could be some flaws in a spread of a budget. So it takes your whole year, you budget for your whole year, and the system spreads it out based off of prior years. So if prior year we had a really bad October, it's going to say this year's October was really bad. And then it will, obviously the November, December, you'll have pauses on that budget because it's based off of the historical information that we had last year. And I do remember last year's October was a bad month, or maybe September, but one of those months were a negative, and so it would have taken that information and assumed that we'd still have that same decrease this year. So you'll see probably in the budget in November, December, definitely January, February will be a positive on the budget.
So the budgeted numbers, it's an automated number. The system actually creates that for us.
So yeah, so I was gonna go to that too. So in a sense, yeah, so we take the first 8 or 9 months, depending on when we start the budget and what we want to take, but it's usually 8 or 9 months of the fiscal year that we're currently in. So we start it in the spring. We'll look at all the historical, the system will take that and it will annualize it for 12 months. And then we'll go in and we'll do tweaks of, okay, we know this is gonna cost more. We know we don't have this contract anymore, so we'll take that down. We know we need to add increases for salaries or add people or take people away. So then we tweak the numbers that the system has budgeted for us off the historical. And then,
So real quick, for that, like, to add to that point is, like, last year, I believe when that did happen, like, the raises all hit in October. And that was the first time that they hit, because they were done in September.
yeah,
and
they hit September, yeah.
And then, so the first time that you had a full month of that was in October, so that brings numbers down. And so to her point, there are certain things that'll hit, at any time of the year, depending on how we roll out certain things that we know that anytime that we would do, in the future, if we said that we were gonna do raises at X time, we would know that that following month, we would see a dip in the revenue or in our bottom line, because that's added expenses associated with that.
So because the system too, we have PTO liability, we accrue the liability for the PTO based off of current rates. So when the rates are updated, now the system has to increase that liability for that month, and it reverses and then we accrue and it reverses and accrue. That's what an accrual is. So you'll see a big increase for that first month when the raises happen, because it's like, oh, we have this bigger liability now that we have to keep on the books that we weren't keeping on prior because the increase in the rates. So what the budget does, and then we come up with this is what we're gonna have for the year for the budget. And then the system spreads it across the year based off of the historical 12 months. And like, okay, this is what we believe it's gonna be based off of what you say the total is and what you guys were for the prior 12 months.
Cause it kind of seems counterintuitive, right? Because we budget a negative number. But it wouldn't be true if we budgeted for a positive number, if that historically, we have certain things happen in a certain month. And we say, okay, every month we're gonna make $500,000, for example. And then you have those months where all that stuff hits at a certain time, it's always gonna be a lower number. We're not truly budgeting to what we're actually doing. And so in our industry in particular, you're gonna have situations where you will have a negative in a month, potentially. We always tried to do what we did this last month and make it a positive. But just based off of how numbers go and how certain things hit at certain times during the year, just like they talked about with like our cash flow, certain times it hits and we drop and then we get it up and then drops again. Those things we have taken into consideration anytime we do those. So there's some months that you'll see like where we budget very little, even if we make a little bit, it might be $100,000. And then there's another one where, this is a $700,000 month. And some of it's very cyclical too, based off of where we're at, because we always know we're going to take a dip in the summertime. And so you'll see numbers go down there. And then it usually increases over the winter time.
Thank you for that.
Any other questions? Okay, so I do have the department P&Ls in here. I should specify when I say department P&Ls, these are only the revenue producing departments. There are a lot other departments in here that's just expense that have no revenue. So these are just the revenue ones. And I will, for the board meeting, I'll start adding in either the census to these, so you guys can see like the ER visits for 26 were here, they were for 25 here. So that was a request, so I'll add them onto the worksheets for the board meeting in a couple of weeks, and then going forward when submit these quarterly.
We know what we're doing.
Right,
Yeah. Yeah.
Yeah, the only thing I have of these, this is like, this for when like hospital, right?
No, there should be, I sent for clinics. No, there's clinics too. That's everything revenue producing. The clinics are kind of towards the back. I think I put them in, I had put them in a specific order of like, but they didn't come out here on order. I had them in order when I scanned them of like, who made the more money to the least amount of money. But I can see that they are not in, or, okay.
But my question is, are those monies in that report?
For the professional revenue side of
Yeah,
it,
so
yes,
like you have a contract with. Inspire.
yes, that would be under urology,
Is here.
correct.
Okay.
Yeah. Yeah, that would be in urology.
Yeah.
Correct.
that was just my question because, you know, their salaries also.
Yes.
I know you explained this last meeting, but could you remind me what the deduction from revenue line is again? What does that pertain to?
Yeah, so, say my bill's $100, but, you're gonna promise to pay me only $10 of that. So $90 of that is going to be a deduction from revenue or contractual, because it's our contract that you're only gonna pay me $10. And so I have to write off $90 out of 100, which is basically what Medi-Cal does. Yeah. So yeah, when you hear people saying, yeah,
Because with that, and that's the two, we have a charge master. Central has a charge master, and everything on that charge master is basically saying how much that we charge for whatever service that we provide. And that's the part that I think makes healthcare wonky. Because
you have.
ours are different.
Yeah. Ours are
And we're 16 miles apart, and they're different. Because we got to decide what ours was. They got to decide what theirs was. Yuma gets to decide what theirs is. Everybody gets to decide what those charge masters are. And then it's usually a percentage of that, or in some cases, they're set rates that they charge, that is depending on who you're doing the contract with, whether it's Medi-Cal, Medicare, Blue Cross, Blue Shield, Aetna, whoever.
And so what I probably explained last time is the reason why your charges are set so high, most people complain about, you know, our charges so high, not ours in general, but healthcare in general is so high, is I have a surgery. Medi-Cal will pay me $900 for that surgery. Blue Cross will pay me $9,000. So if I set my rates at $5,000, Blue Cross is only going to pay me $5,000. I'm going to just lose out on that extra money. So you have to set your charges high enough to collect that percentage for those, because most of our commercials are based off of a percentage of the charges. And so that's why everyone's charges are so different and sometimes so high compared, because you don't want to lose out on that reimbursement from certain payers.
So that adjustment is that final.
Yeah.
So it's not an expense that we're incurring, basically. We haven't added more.
No, it's not. It's just saying, yeah, when you see, you know, $500 million of gross revenue, it's not really $500 million of
Yeah.
gross revenue.
Well, it is.
Well, I mean, it
$500
is.
million
It's
gross
not
revenue.
of revenue though.
None
You
of,
can't
none of
say, yeah.
net.
Did you guys have any questions or wanted to see any more on the department P&Ls? I know I had promised some graphs, unfortunately. We're down to 1 accountant instead of 3, so my promise is not gonna happen for a while, so I apologize.
My question about over here on the debt ratio coverage.
Yeah.
You know, you provided the graph, because I was just gonna have you put like November, December, January, you just put the amount in,
Okay.
just so we could just kind of look at it.
I see how it's
But you did it with the graph, so.
That's good. Okay. Yeah, and I added in that line because I remember last time I was like, there's a graph, but I don't actually give you guys the number, so I
Yeah,
added the
so, like,
number in
we
for you.
don't remember.
Yeah.
I looked at it and I go, is this a higher number or is this a lower?
Yeah.
You know, so.
Okay.
I think the graphs kind of, but.
Okay, thank you.
So I think
I'm a very
good.
difficult person about that, as part of the reading of actual numbers, after a while, they all just run together.
Yeah, well, that's why I tried to change the narrative because I even stared at it for a little bit and I was like, okay, I know what I'm looking at and starting, yeah, so.
I'm just trying to review it more often. It's almost like learning a new language, right? You just get more familiar with it.
Yeah.
And then it just kind of starts making more sense.
Yeah. So this is, since it's claim day, I guess, you know, my question always is like, I see there's a drop in this or I see a drop in there, what if we investigated it? You know,
Mhm.
like it's deliveries of really well.
Yes, and I last month, since they did drop a lot, they're saying they didn't drop, they're investigating what's going on, because they shouldn't be that low
No.
for this time of year.
Yeah, I tried it right away and I thought, but I mean,
Yeah.
someone else delivering someplace else or,
Yeah.
you know, are we not doing?
Yes.
So, unnecessarily.
You're welcome.
Yeah. Good with the plan, believe
Yeah, the Octobers haven't gone to the board, right?
No,
So,
this is the
yeah,
first
we
time,
would
yeah.
approve it for.
To move to
Yeah.
the Bruce.
And I'll just add the stats to this.
It's more like receive, it's not really, you don't approve,
Yeah.
you know, you just like receive and file.
That we.
You reviewed it, you're okay with it?
I so move that we review. And approve.
Second, all right, any further discussion? All in favor? Aye. Any opposed? Other items, C, discussion and or possible action to recommend to the board of directors approval of authorization to approve the professional services agreement for urology in the Harlem.
Yeah, so she's not here. This is the contract for Dr. Indahara. So, Dr. Indahara is currently on a contract that he, asked out of and gave notice. So his final day on his current contract is December 18th. And part of that has to do with the change in his schedule. Our current schedule, he's got to be here, 4 days or every week essentially. And he wants to be able to, he's got personal things he wants to take care of. And so, that's part of the reason for the change, but it is a change from how we've done contracts in the past where it's a straight rate that we pay somebody to this one, which is an RVU based. So he gets paid for the work that he does. And that is the component that there might be that there are some conversations that are being had with Dr. Indahar right now. So there could be some minor changes to some of the things within there. But the thing that we're asking for at this point in time is like, or the approval for you guys, as it stands from a monetary standpoint. And then if there are further changes, as we kind of go back and forth on some of it before the next board meeting, those would go to legal for review, before, they would hit the board. But, monetarily, that it's set up for him to get paid based off of the service that he provides. Well, that's where Dr. Jurgis will come in. Or January 2nd. Or no, because that's Friday, so it's like the 4th, 3rd, 4th, 5th. Yes. Yeah. And we've been trying to do it, like he's already doing it right now, like, because he's already taken the time off. He's just out of compliance with his contract at this point in time. And so he's already doing it. So we're making it work with what we have available at this point. Yes. Yep.
Yeah, and that's my question. My only concern is that, we have a full.
Yes, there's a more than full. Correct. Yes.
My concern is how we're gonna fill that.
Yeah, and that'll be Dr. Jurgis. No, it's a fair question, but that's where Dr. Jurgis will come into play because he'll be a full-time provider for us. And quite a bit. I can't remember off the top of my head. I think he's 20 something plus. Yeah. Oh yeah. Yeah. And they've, yep, we already approved it. We didn't know the date he was coming at that point in time. We approved it so that we could get it to him and get him signed, and now we've got him coming. Yeah, he's coming from Texas, but barring, like, he's still going through the process with the med staff team and getting credentialed. And so we got to hit it right on their next meeting. So that, because normally they didn't have one in December, but they're going to this time, and then hopefully we can get them. They'll go through and get approved there, and then, but there's a lot that they're trying to get pushed through. Yeah, absolutely.
I think it's good for the board.
And how do we get that to the public also, like the
Well,
kind of promote?
We will, yeah, that's on us on the marketing side. That's one of the conversations that we had as an executive team. You know, we talked a lot about the fact that because, and I think we talked about this at the board meeting as well, we haven't done a good job of getting our providers out there and really marketing them because of the situations that we've been in. And honestly, that shouldn't have been an excuse, but that's what we've used as an excuse not to do it. And so that's our efforts going forward are to make sure that we're marketing our folks and helping the community know and understand what services we have, what's available. You know, changing more than like right now, we've got the IVHD coming together kind of things up there as far as what people see on the billboards. Those will start to change to being more specific to service lines and things like that will go out will be more specific to providers and the service lines and the things that we offer so that people know what we can do as IBHD going forward.
Yeah, we actually have a pretty high caliber roster here.
Absolutely.
Definitely, you know, help our hospital, but I'm sure they would appreciate it, they would benefit. from it.
Yeah,
And it's kind of.
Especially if they're doing the RVUs, it definitely helps them.
One of the things they get from working with us is we actually also go through the.
Mhm.
Help them.
And some of the things too, is we've looked at the data, like we've talked briefly about this as well with some of you. But we have a lot of things that are going out of the community. And my guess is if we asked some of them, they wouldn't even know that we provided the service. And so that's on us, right? And that's where we have to do a better job in that situation.
And this contract was reviewed by Paul, my partner on the health care team.
There might even be something on our website. On our website, ask us if we provide that service, and maybe they can even.
We do have like on the name, we do have it all listed, all the stuff that we provide and the doctors associated with that. But I think when we do a refresh.
Hospitals going, like,
Yep.
What's going on in Health Central, what's provided here, so they just go one direction or the other.
Yep. Yeah, absolutely.
Saying,
Simply
my
finance.
brain is processing here. So we kind of have a reduction here with Dr. Andohara, but then we have the complementary contract with the new doctor.
Correct.
Our services and all of that are okay, so financially, I guess I would be okay with this contract from a financial standpoint moving forward, so I would, if we don't have any other discussion, I would make the motion to recommend the approval of the contracts, definitely from the financial side.
Chance for more discussion? Okay, all in favor?
Right?
Aye. Any opposed? Motion carries.
We certainly don't want to lose.
No. No, and he has no desire for that either. He loves the area, wants to be in the area, but he's got a lot going on. Well, that's what we can, like I said, there's some other stuff that's going back and forth that he wants to make some potential minor changes in. But the financial part of it is what we want. You know, like it's, you guys are okay with that. The minor things that are gonna be from a contract, like little pieces here or there that will change, that's what we'll go through legal with. Well, it's not happy with it, but yeah, that's like everybody would be more happy if we gave them like
Wait, one.
way more money and didn't tell them I had to work as much for it, so. Yeah.
Moving on to item 9, item for future. Item for anybody else?
Yeah, we'll probably bring back amended bylaws. And then other than that, we'll have
Then-
standard discussions like monthly financials. I don't know, yeah, any contracts that are ready.
And then from here, are we taking this to the board to be able to approve the stuff to go to the consent calendar for them to, like, so that they,
So now that the
bylaws are-
bylaws are approved, we can just place all of the items under 200K that the finance committee has recommended for approval on consent.
Right. I can't remember if we had the conversation with the rest of the board about that, that's how we would want to do it. So that when they see it.
Yeah.
Okay, okay.
Director Garcia mentioned that it's part of the finance committee update.
Okay,
And so, what we'll do is place them on consent.
And
And
then they can
then,
pull them if they want to.
yeah, if the board is like, hold on, why is this $180,000 contract on consent? We'll explain. Well, in case you forgot, or in case you missed it from last board meeting, the finance committee's bylaws and recommendations are for items valued at between 50K and 200K to be placed on consent if they're approved by the finance committee. If you want to see that number reduced, let us know and we'll amend our bylaws and say, okay, that should be 100K, 50 to 100 or 50 to whatever. Otherwise, finance committee thought it was appropriate to have items between 50 and 200K on consent. You can always pull up board members.
Our overall board bylaws need to reflect that now as well.
No, they don't, because it's something that this committee is action, this committee is taking. So you're recommending to place them on consent. And so that's the recommendation that we're gonna bring forward to the board. And then if the board, they can accept that recommendation or not, and so it'll be a two-pronged thing. One, they can accept the recommendation to keep it on consent by just approving the consent calendar. They can say no, pull it from consent, and it'll be considered a separate item. They can approve it or not approve it at that point. And then if we see that happening regularly, we can say, okay, you guys don't seem to like having a contract on consent. You guys want us to do our things differently. Because, you know, they might really appreciate it, but no one voiced any concern at the last board meeting when you reported on it, so. Right, exactly.
We'll tell them that.
Right,
We're here, they're going through this, but.
yeah, and,
now I have to listen to it again.
you know, and it's something that this committee and the members could tell the board if they express, like, did anyone ask any questions or did anyone, et cetera? You can always direct them to the meetings and the minutes and say, hey, the meetings are recorded. If you want to look and hear the discussion we had, because board members could also log into these meetings and listen in if they wanted to. If they wanted more in-depth
Mhm.
discussion on any particular.
Are these that posted on our website? Is that where we find?
I don't know. I have found many posted on the website.
Yeah, post your agendas.
Yeah, and
Yeah, there's an agenda page. I'm on it right now. Yeah, so it looks like that. And then this is our meeting, and then you can see the recordings here. You can just play them from past meetings. And you're not obligated to do that, by the way. I mean, that you do it.
At one point, and we were a little behind.
Mhm.
Yeah,
There are some that.
yeah. But again, you're not obligated to. It's like a really nice thing that you do as a matter of transparency, because really all you need to do is have minutes available, not even on your website, but just have them available if someone asks for them. So the fact that you have them on your website along with the recorded meetings is like pretty
That's what I
awesome.
do on Friday nights.
Ah, you watch the meeting?
We watch all.
Poor Dave.
With his popcorn and.
I absolutely do. I was absolutely bored.
But he watches it on times two.
I do, yeah. Because Dave has no life.
No.
My kids are all grown, so I'm too old to go out on Friday night. My kids are too old to, to keep me up to Friday night with the boss.
I do know the C webinars, I'm like. Then I just take the test at the end.
So the one question I did have that's for the next board or committee meeting is, do you still want to have that committee meeting December 22nd at 2 p.m.?
Yeah.
Okay, just making sure, because a lot of folks take December off.
How about you?
I'm almost positive that I'm definitely in town, and I think it's on my calendar. So I'm in if you guys are in.
Yeah, that's fine.
Yeah,
And then you might be able to do it virtually now that.
after January.
After
After January.
From
The
the law.
22nd.
It's the 22nd.
22nd.
Usually on a Monday.
Yeah, this one we just, I think there were.
Yeah, there was a
Yes,
change.
thank-
Oh, yeah, thank you for doing that. Yeah.
I can't remember why, but it's just, I don't know.
It's all right.
week it is now.
Yeah.
The 11th.
December 11th.
I know, my wife is singing. I actually sent a text to to Katie on that, saying, hey, can we move this up? Because their concert starts at 7
For the
and
December board meeting?
yeah. So she said she was gonna talk to the board about changing the time. Yeah,
Speaking of, being able to do it remotely, it looks like in January, I'll need to do that. For, yeah, I'll be, in, Sacramento, not Sacramento, Monterey for a real for business meeting that week.
So we'll, bring that, the way it would work is we would bring it to the board, they're gonna say, yeah, make those findings. I'll bring it to the resolution to the January 8 board meeting, and every committee meeting after January 8, you'll be able to do their report. So assuming the board's on board with the plan.
so I guess since you guys are here, I'll ask the question and I can report it to Katie. Would you guys be open to doing an earlier meeting on the 11th? And if so, how early? Yeah. He's gonna, yeah.
Make it do it as late as possible. Friday night, 8 o'clock.
Well, there was one time that they were with us until midnight
Yeah.
their time. So,
I'm good anytime after noon.
yeah, I'm fine, like 4 o'clock.
I can do that. I have like a virtual board, it's another board I'm on for nonprofit. It's a great organization. And, happy to be on that board. But, I can work around that and still join 2 hours. I'm open.
Alright.
Not so much.
So you try, I tell her 4 o'clock. All right, I'll tell her that we're okay with 4 o'clock and see if she's okay with that, and then can check with the others as well, and then,
I'm available anytime after 2, like 2 on.
okay, all right.
Yeah, then I think it's 3:30.
Yeah, well, we'll be
It's
in El
El Centro.
Centro. Yes, so it'll be even closer. They're doing the Messiah concert, yeah. My wife sings in it, and so, yeah, I definitely need to make sure I'm there.
Better be.
Yeah. Yeah, she has a solo part in it this year, so.
Fine, great.
Yeah.
Right.
Yep.
The other item for future agenda? Okay, we'll go ahead and adjourn this meeting at 4:25 p.m.
Good job, guys.
Happy Thanksgiving.
I know, happy Thanksgiving, everyone.
I will.